going to start off like for video purposes. I'm going to introduce this is the TriNetX Summer Bootcamp for 2026. This is week one, navigating TriNetX and developing a project. I am Dr. Daniel Novak, Director of Student Scholarly Activities in the UCR School of Medicine. And this is, as I've noted before, my third time going through this boot camp and training folks up. If you are coming to the School of Medicine, I will routinely refer you to these videos because I've tried to include a lot of what I know in this video series, and hopefully this will get you, ready to go and out of the gate to develop good quality projects. Um, Again, if you have questions, I'll be monitoring the chat on the other side. Just a little bit of information about me for those who are meeting me for the first time. I am, as I tell students, hashtag not that kind of doctor. I'm not a physician. My doctorate is in the social psychology of education, which is an area called learning sciences. But it's been a great privilege to work here at the School of Medicine at UCR to develop this secondary data analysis program for our students to, in addition to my role as connecting students with research opportunities, part of my role is to teach the research and inquiry thread. We're going through a rebranding. It's going to now be called the research and inquiry thread. And in this thread, students spend 3 years going from start to finish developing a research project. When I first started, we did not have a consistent way for students to learn how to do research. About 2.5 years ago, 3 years ago, we got involved with TriNetX and started connecting with them. 2 years ago and a bit, we joined the network, and we're now going into our third year of implementation. And we've just seen students do incredible work, publishing in national journals, publishing in high quality places, getting presentations into national organizations, and really being able to participate in the great dialogue of research. And specialties that are not directly reflected at UCR School of Medicine. So I'm very proud of everybody and proud to continue supporting this work as we go. No, but I do want to note at the very beginning, this is very common in medicine, is to make sure that I am disclosing that I have no formal funding from TriNetX. I don't have any kind of relationship with them beyond our UCR contract. I don't have any shares or funding. I don't take any money from them. I don't get any sponsorship or whatever. I do this purely to support our students as they learn about clinical informatics research and clinical epidemiology research. And it has the side benefit of being viewed by people around the world. The last year's series, if you add them all together, had something like 20,000 views on YouTube as of today. So, but TriNetX does not in any way give me anything beyond anything mandated in our contract, though they are aware of these videos and they have given me some feedback. However, some salary time for this bootcamp was originally paid for with funds from a National Institute of Health U54 grant by UCR and City of Hope. I'm not doing anything extra, just doing this as part of my work and my regular job. Like, I would do this anyway, but some of my time is paid for as part of the City of Hope work that we do through the U54. Here's the kind of overview. We're going to be meeting Tuesdays from 5:30 to 7, ideally getting out around 6:15 or so in Pacific Standard Time. The first week, we're going to go through a very kind of structured approach here. First week is navigating TriNetX and developing a project and just starting, like, how do I even know what kind of project to make, right? This is a very common question from our students, so we address that this week. Week 2, we're going to move on to defining and exploring cohorts, because cohort-based research is a whole way of thinking. It's a whole methodology that requires understanding a little bit about how retrospective cohort and observational research is done. So we're going to talk about that. Week 3, we're going to look at comparing cohorts and propensity score matching against some of the really cool stats behind that TriNetX facilitates. In week 4, we're going to talk about pretty much the most common process for statistical analysis process that people do with TriNetX, which is comparing outcomes. And then we're going to look at the peer review and doing a peer review process on that. Week 5, I added this last year when they added the Cox proportional hazards model tool. We'll look at that and a different tool called treatment pathways. These are a little more, these aren't as commonly used, but when you're doing a study, they can really, really, really add a lot of additional power to your analysis, a lot of additional richness that's going to make it more competitive in the big marketplace of manuscripts that come through journals. Week 6 is posters, manuscripts, writing tools, and AI, and some additional publication toolkit components that I've put together over the years. And I'll be sharing a little bit about that today, but coming back to that at the end when we talk about bringing your analysis together into a tangible artifact. Um, Bootcamp objectives. At the end of this, you're going to learn to navigate the TriNetX interface, identify worthwhile projects, compare outcomes between patient cohorts, and use propensity score matching to reduce confounders. That's the big picture where we're going to wind up here. But a lot more than that. Those are just the kind of top level objectives. Today's session, though, we're going to get a big picture overview of TriNetX. I'm going to talk about navigating TriNetX and then developing a project. This is going to be very similar to some of the lecture material that you would experience if you were in my course in medical school. But I'm going to have a little more time to discuss things than I usually do in that course as well. Just taking a look through the chat. Thank you guys for introducing yourselves. It's great to meet you. Welcome to our incoming students. So each session though is going to include kind of two parts. There's the technical training, and I know I've worked with medical students for many years now, and I know some of you are like, just give me that high yield stuff. Just tell me what buttons to click. And I want to press a bit back and say, actually, in order to make use of TriNetX, don't just get in there. People say this all the time. I'm just going to get in there and play around with it. Don't do that. You need a conceptual understanding of what you're doing, or the research you'll be doing is just going to be a bunch of junk, and you're going to be polluting our broader research ecosystem. So it's really, really important to pay attention to both the technical stuff that I'm going to talk about, like these are the buttons to click, this is the stuff you move around, that's the stuff that people think of as like the real stuff. But what I really need you to understand is that the conceptual components, how to think about the data, how to think about the platform, how to think about your project, how to think about research generally is just as important, if not more so. Don't skip either part. You really both need that conceptual and the technical parts to make this work. This is a big lift, though. We use 3 years of our curriculum between MS1 and MS3 for our students to develop a TriNetX project from start to finish. This is my three cohorts have now completed their projects, and they've been fantastic. Our faculty think they're really high quality. I think they're really high quality, and I think that students have really learned the research process from start to finish in a much more consistent way. So doing this in 6 weeks is kind of a big lift here. It's a lot of concepts get thrown at you, and I usually space this out over more time. But that's why it's a boot camp. We're getting you ready really quick. So I'm trying to provide you also with some additional resources. We do have our scholarly activities portal. This is a website that I created when I came to UCR. Let me just pull that up here. You can see, and I'll put this in the chat. This is a link to it. If you are one of our medical students, you will be pointed to this for a number of different resources over time. You can see over here under TriNetX resources, we have a lot of different stuff. I've got a little database of publications from students that we update periodically, publications and conference abstracts. We have a number of research resources. I pulled together a lot of free textbooks. I believe anybody with a UCR account or even a UC account generally, a library account will be able to access some of these things. These are some high quality TriNetX studies that I've imported as well for you to view if you want to take a look at it, and some of TriNetX's own help videos and documentation on their platform. I also created and trained a ChatGPT chatbot on the TriNetX data and their help documentation, stuff like that, to try to make it so that it's a little easier to use AI to plan your research, because vanilla ChatGPT, vanilla Perplexity, vanilla Claude, vanilla Open Evidence, they don't know anything about TriNetX actually. They're just going to parrot what they think what a TriNetX project would look like based on their existing data. So it's really important to know that a lot of times if you just jump into ChatGPT and say, how do I do this in TriNetX? It doesn't actually know anything. So I want to warn you about that. This AI tool is a little better. So if you use it, it might give you some better responses than otherwise. Um, I also have a number of templates that I provide to folks as well. These research templates for science presentations and posters are what I require in my course. They're in Google Docs, so if you click on these links in on our scholarly activities portal, you'll get copies of them. I have poster templates and I have cohort diagram templates that are all really useful, as well as like some general templates like mentorship communication emails, citing TriNetX in your papers, and descriptions of TriNetX that you can, use and send to mentors and stuff like that. So these have been some requests from students over the years. Um, I have human subjects approvals for this. You may not use this without filling out this form, but I do have the ability to collect and then provide human subjects approvals should you need this later on. But using this without my approval is expressly forbidden. And if I find out or see it in one of your documents or something like that, and I don't have you logged in my form request, I will take away your TriNetX account, basically. So please don't put us in that position. Talk to me if you don't understand why and when you would need this, and also fill out the form should you need it for a conference. Um, TriNetX does have publication guidelines and requirements. That's broken, but I'll fix it coming up. And I also want to indicate that we have a TriNetX publication toolkit that I've put together that has a whole range of additional tools that you can use on top of TriNetX to get some additional value. That includes a Kaplan-Meier curve maker, forest plot generators, bar graph makers, love plot generators. And we're going to talk about all of these later on in lecture 6. But should you need to develop some of these things, I can help you with that as well. So that's the scholarly activities portal and some of the TriNetX based research resources we have there. We also have, by the way, the recordings from the bootcamp on here. Here's 2024. Should you want to go back in time and see me when I had slightly less gray hair, or 2025 and 2026 will be available once we have completed these. So that's the big picture of the resources available. If you're going to go read one book about clinical research, just one about this kind of stuff from randomized controlled trials and observational epidemiology, this book is really great. I believe that there is an available version on the library. If you follow this link, it'll take you there. If you have a UCR library account, you should be able to access this. I'll put this in the chat right now. But it's a little, old, but some of these things are perennial. They're never gonna get out of date. Um, and it does a really good job, especially I think chapter 7 talks about some of the limitations of observational epidemiology, some of the things you need to keep in mind as you're doing clinical research. Um, it does over-index on the importance of randomized control trials. Randomized control trials, as we might talk about a little bit more later, are the gold standard for research, right? Because, as you'll learn in my class and a little bit in your biostats and epidemiology approach, the ability to control whether somebody is receiving a treatment or not prospectively gives you an enormous amount of ability to determine what factors are being introduced to these individuals to try to reduce random variance or even systematic bias in your analysis. And that's really important. However, randomized controlled trials are incredibly expensive to run, and they are very short, typically, maybe a couple of years max, right? You can't usually do randomized controlled trials over multiple years just because of the cost and the danger that might be involved for the patients. Um, and typically they're not necessary for most things like drug trials and stuff like that. Please be aware, you should never take a drug that was not rigorously evaluated with things like randomized controlled trials. However, there are limitations that observational epidemiology and real world data we're going to talk about in the context of TriNetX can actually help us do that you can't really do with a randomized controlled trial. So this book will help give you a sense of some of those important dimensions of observational epidemiology and randomized controlled trials. As I said earlier, we have links to the recordings. Those previous ones have been viewed like 3,000 times, but this first video in the 2025 edition was viewed like 7,000 times already. So we're getting a lot of people all over the world are watching this as well. Requesting a TriNetX account. I do want to emphasize, if you are not a person who is at UCR School of Medicine or at UCR, don't email me. I get emails from people in like Vietnam and Taiwan and Eastern Europe and all over Central Europe, I cannot give you access to TriNetX. This is only for people at UCR. You're welcome to watch the rest of the video, but I can't do anything for you. Um, okay, let's talk about TriNetX and health informatics more broadly. Um, by the way, when you're gonna stumble over this for a little bit, let me just help you out here. It's TriNetX, right? The idea is it's a clinical trial network X, right? So TriNetX. But you can say it, they say it, at least as far as I can tell, like genetics, right? TriNetX. It's easy, right? TriNetX. We're going to talk about health informatics more broadly. So, what is TriNetX? Well, TriNetX started out and still is a clinical trial matching platform. And the idea was if you have a drug that you want to test or a therapy or some research you want to do, and you want to do it at multiple large academic medical institutions, the in the past, you had to call up each of these hospital systems and ask them, hey, can you check your electronic health record to see how many people have this disease or have this condition or are between the ages of 18 and 25 and have had cases of uterine fibroids or whatever, right? And they would have to go, and there's always this long process of identifying potential participants. So TriNetX was developed to and eventually became connected to in the US right now, I think it's 70 health systems across the United States in multiple states, including private health systems, but also academic health systems as well. Um, and it pulls the electronic health record data out of these systems. Well, it doesn't really pull. They give up their data or pass over their data every periodic whenever they refresh it, and it gets integrated into this federated system. So when you query TriNetX, when you look for a group of people, it checks all of these systems to see how many patients in those systems fit those parameters that you're looking for. And no data leaves those systems necessarily, but it's checking each of them, querying them individually. So it's a pretty spectacular piece of technology. Um, and right now, yeah, it's connected globally to like almost 200 health systems with 194 million patients globally. Right now, it's about 70 health systems. The number of health systems connected changes depending on who's participating at any given time and who's not. But some of these health systems are very large. UCI, UCSD, USC, Johns Hopkins, Virginia Tech Carilion, University of Iowa, University of Alabama, on and on and on, plus more countries globally. I think 7 countries, uh, Taiwan, places like Taiwan, South Korea, Japan, Russia, Israel, Germany, France, systems in the United Kingdom, things like that. Um, what kind of data do these systems provide? Well, all of the data come from electronic health records. So I want to be clear. Data that cannot be found in electronic health records will not be in TriNetX, right? That means things like you're going to be able to find things like demographics, including age, sex, language, racial and ethnic category, by which we mean Black, white, Asian, Indigenous, Pacific Islander, or I believe Hawaiian and Pacific Islander, but also Latino, and marital status. It's going to have diagnostic codes in the form of ICD-10 codes, procedure codes in the form of CPT codes, and ICD-10 procedural codes. It's going to have drugs, um, labs, genomics, visit types, and more than that, even. So there's no HIPAA information anywhere in this platform. They put really strong guardrails in place to make sure that it is not possible for you to identify individual patients using the information in TriNetX. And we help TriNetX to do that by basically being good citizens and not trying to circumvent their HIPAA protections. So, um, the average age of the patient record, the length of that patient record is about 7 years. And the data is refreshed for most organizations weekly or monthly. So if you're working on it, you're going to be seeing pretty up-to-date stuff in there. The time, just a quick note, is date shifted, meaning, usually they move it. I think the average is like 2 weeks. So you can't tell exactly what day somebody visited um, a clinic for a particular purpose because by date shifting all the data, it makes it impossible to know basically to violate HIPAA on that by making it impossible to know what date of service something was provided. If you don't know what HIPAA is, and you're in America, you should familiarize yourself with it. The different HIPAA identifiers are really important. So please make yourself aware of that. Um, Thank you for those who are joining. I know we had a little bit of snafu on the time for this, but I'll be posting the video tomorrow so you can go back and review the first couple of minutes. I know there was a little bit of an incorrect time on there. So thank you for joining. You haven't missed a whole lot. Um, TriNetX, so what are the data sets like in here? Well, as I said earlier, there's a global data set. It's actually closer to like 194 million patients today in the global data set. Within of those 194 million patients, 115, 116 million of those are in the United States and in the research network. We do have, if you're at UCR, we'll give you access to the UC Collaborative Network, which is UCI, UCSD, and UCR pooled together. It can be on the order of 1.3 to 2.4 million patients, depending on who's updated their data and is connected. And then if you are at UCR and you are being supported by a UCR faculty member, we can give you access to the UCR specific health, which again requires overview by a mentor. Geography, by the way, is obscured below here, right? You know that the UC network, UCR Health is at one of the UCR clinics. The UC Collaborative Network is somewhere in Southern California. But once we get beyond that, it's a lot harder to tell where people are located. So we're going to talk about it in a moment. Geography is not really a great way to use TriNetX to assess outcomes. So looking at people by zip code is not possible. Let's talk about cohort-based research for a sec. So TriNetX thinks in terms of cohorts or groups that share common characteristics. Those common characteristics may be demographic or medical or drug-based or any number of different ways that you can define them, but they have something in common. They have more in common together than the groups of the general public. So that's kind of how cohort-based research works in a broad stroke. Studies are retrospective, but bear in mind that cohort comparisons can be used to create natural experiments using real world data. What's interesting about that, and we're going to talk a little bit more about this later, is it's possible to do stuff in TriNetX that would be unethical to do in the real world, dangerous for patients in some way, for example, to deprive them of an important medication. However, if patients in the real world, for some reason or another, did not receive that medication, either because they declined it or some other factor, right? It didn't exist yet or something like that. It enables us to actually look at the consequences of that. It can also do stuff that might be expensive, right? For example, following hundreds of thousands of patients on semaglutide and looking at their ophthalmic outcomes, right? For example, or their outcomes in peripheral arterial disease or something like that. So things that are prohibitively difficult to do at multiple sites that are expensive, would require federal money or nationally scaled research apparatuses to do, we can do in TriNetX in a retrospective fashion. It does use propensity score matching, which we're going to talk about in I think session 3, to adjust for confounding variables. Propensity score matching is a technique for essentially using statistical approaches to match people from each cohort that are statistically random from each other. They don't all have, so you don't wind up with a cohort full of very sick people and another cohort full of very healthy people. You wind up with people from both groups that have similar health profiles based on the characteristics that you think and that TriNetX can help you see might be relevant to your study. It's very interesting. It's not without its criticisms and critiques. We're going to talk about that when we get to it, but it is definitely a very common way these days to adjust for confounders and bias. One of the reasons I think TriNetX is such a great choice for you guys is compared to other large scale data sets, this is bar none the best interface, right? None of you have to learn any code to use TriNetX. You don't have to learn Python. You don't have to learn SQL. All you have to do is use your brain, and the platform will allow you to do this. So, by the way, we'll talk about this in a couple minutes. TriNetX is making some updates to their platform. on this coming Thursday. So you might find when you look at this days, weeks, months, hence from now, that there have been some changes to this, and this should be reflected starting next week. But their builder is very easy to use. I'm going to take you through some of the kind of key features on that today. Um, Another reason that this platform is such a powerful resource for our students and for our faculty in conducting research is that it has built-in statistical tools. These are all built on R packages, so they're very consistently understood in the literature. They're very accurate. The TriNetX people test it to make sure that they're actually getting outputs that are related to what they think they should get. And they can help you see a whole bunch of different kinds of trends going on in your cohorts that are of value to clinical research. So you don't have to know how to operate a statistics program to use this tool. You don't have to know R. However, you do have to understand what the statistics mean and how to understand whether your statistics are good or garbage. So that's something we're going to talk about a lot going forward in our analyses. And also understanding how to falsify our own analyses, right? We want to test our analyses in a bunch of different ways so that we can understand, for example, including or excluding different people from those groups to see whether our results are good. We might call those uh, um, I'm blanking on the name right now. We would call those kind of, you can think of them as attenuation tests, right? So if we include people with type 2 diabetes versus having them be propensity score matched versus excluding them from the cohort altogether, how does that impact our results? That can help us understand whether our analysis is robust or not. Here's a little bit of details about each of the individual tools and what they're useful for. The most common one by far is the compare outcomes tool. It's the most, broadly used across all the 2,000 plus publications from TriNetX based publications out there, and it's the most common. Um, it is possible you may see in your interface a request dataset function. I have that locked for most of you. I'm going to say for people at UCR, I don't know about you at other institutions, we are not currently allowing you to download data out of TriNetX. Couple of reasons. First is you would have to get human subjects approval for it, and we would have to get a data use agreement with TriNetX signed. And neither of those things are going to be particularly easy to do. The second thing is we would need to have biostatisticians help you manage that data. It's very, very cumbersome to use. It's not just a big Excel file. It's on the order of gigs of data that can come through. It's every single, it's row level data. So number one, you have to protect it much more carefully. The IRB is going to want to know how are you protecting it? And number two, since it's row level data, it's every single thing in the person's health record. And you're going to have a really, really good understanding of how to use it. So we are not facilitating that right now. And you'd have to come and talk to me at great length before I would agree to try to get your project out. If you have truly, truly, truly exhausted what TriNetX, the analytics platform, the internet, the web browser-based version of this can do for you, we can talk about other options as well. Okay, so we're going to talk about good use cases for TriNetX, but first we're going to talk about bad use cases. So a lot of people's initial project ideas start with some of the following things, but I just want you to kind of understand the limitations on this, right? Bad use cases for TriNetX, questions related to geography. People will start out with things like in the Inland Empire or in Southern California. No, we cannot tell geography. And part of the reason is geography can be used, for example, zip code can be used. It is a HIPAA identifier, zip code at the 5-digit level, right? Is an identifier. So also TriNetX to protect their healthcare organization partners, they need what they call a 3+me group, I believe. So it's 4 groups have to be in the same geographic zone before, and you have to be drawing data from at least 4 groups in a given geographic zone before you can do any kind of analysis or any kind of information about that. And you generally just can't include that in your analysis. So you can't look at, outcomes for people in the South or something like that. It's not possible, not even by state. So you can do it at the national level, the global regional level, or the international level. You can't do anything related to insurance status. There's no insurance information in TriNetX. This is a very common question. Do patients on Medicare? Do patients with insurance, without insurance? Those questions cannot be answered with TriNetX because with the general network that you guys have access to, because it does not have claims data included in it. So park those questions for some other project in the future. For those who are hospitalists or hospitalist adjacent, questions about length of stay are not available. It's possible in theory to do some of these analyses in downloaded data sets, but as a rule, nobody does because length of stay is computed differently in every single hospital and in every single department sometimes. So sometimes in a hospital, when you go from the emergency room to a room in inpatient, those can be two different stays. Right. So length of stay is almost impossible to calculate broadly. There are certain specialized data sets that do find ways to calculate that very specific thing, but it's not going to make a good use case for TriNetX. How long do patients wind up in the hospital following this kind of infection with this treatment versus that kind of infection? That's a very common question that hospitalists have, but this is not the right platform for that. So just FYI. Another thing that doesn't work very well, sensitive data types. So neonatal questions. For very important reasons, protecting babies, you cannot do analyses on codes that are typically, this is called the P series of the ICD-10 codes, that are that are related to neonatal outcomes. So birth defects, certain kinds of things that are immediately part of for the first 30 days of life that are used, you can't do. However, there are certain ways you can look and see whether somebody has had a birth defect of a certain type or has had a disease of a certain type that might have originated in the perinatal period, but you can't specifically use the perinatal codes to conduct comparisons in the platform. The second sensitive data type is accidents, incidents, or violence. So gun violence, which is sad. Someday they say maybe when the data set gets large enough, which would be tragic because that means there's going to be more gun violence cases between here and there. But ideally, some of those codes may become unprotected in the future. It'd be amazing to use this as a surveillance tool to look and see how gun violence occurs in America. This is a huge problem. But deaths in war, car accidents, terrorism, things like that. Those can't be monitored in TriNetX, can't be accessed and compared for certain folks. My favorite one though is the effects of weightlessness are restricted. Can anybody guess who might be the people who are impacted by weightlessness? And following on that, why we might not be able to look at it? Yeah. Jose points out astronauts, right? Astronauts would be the people who are impacted by the effects of weightlessness. And there's only like 500 astronauts in the whole world, right? People who've ever been to space or been impacted by weightlessness for that length of time. So those people are restricted because it'd be easy to figure out who they are. Questions related to ambiguous or qualitative outcomes or information not collected in an EHR, probably not going to be a good project. The reason is, do cohorts, like for example, patients in cohort A report less pain than cohort B? Pain measures are not uniformly collected unless they're necessary in the EHR, for example, to justify provisioning opioids or something like that, right? So there are not really good uniform pain values in there. There are codes for people who experience pain, but it doesn't give us like, do people who have this medication following a surgery report higher levels of pain than people who don't? That's really difficult to say. You can approximate that by looking at different kinds of medications that people who are in a lot of pain get. For example, NSAIDs versus opioids, but you can't, it's very, very difficult to find lab values that directly reflect pain. Similarly, cost is not reflected in here. So what are the comparative costs of treatment A and treatment B each year? You would have to go, number one, cost in the American context is a crazy thing to talk about, right? Because there is no such thing as a cost of procedure, right? If you have insurance, you pay one amount of money for an MRI. If you don't have insurance, you pay another amount of money. If you go to another hospital down the street with the same MRI machine and the same electrical like bill and everything, you would still have a different amount of money being charged for somebody to get an MRI. There's no standardized thing. So Computing costs for treatments in TriNetX is not possible, number one, but number two, hard to do on anything. So you really do need a medical economist to help answer any of those kinds of questions. Though we could approximate stuff like how many people are getting this procedure, figure out across the country what the average cost is. If you can even figure that out, some hospital systems don't have to tell you, and then try to multiply those things. Okay, I talked a lot about what's not possible, right? Total downer. Sorry about that. But it's good to start out with knowing the boundaries of the box that we're working in. TriNetX, in many ways, doing research in it is like haiku, right? It's a very bounded art form. But once you understand the boundaries of the art form, you can iterate and do a lot of really creative stuff inside there. So, great use cases, risk likelihood, how likely somebody is to experience one or another kind of outcome. Disparities in treatment or care. That's something that's really important. There are something like 12 or 14 million African American and Black patients in TriNetX, 12 or 14 million more Latino patients. We can look at things by language to look at very specific groups. There's a whole different ways to look at people with different kinds of disparities, whether they're disabled or disabilities, things like that. That's all possible to do. There are long-term outcomes for patients, and we can talk about long-term in terms of 10 to 20 years instead of most studies, which end out at 5 years. So, time can be your friend in some of these studies. We can also look at experimental conditions that might otherwise be unethical or impossible to replicate in the real world. As I noted earlier, not giving people a medication is unethical in many cases. However, if they choose not to have the medication, you can look and see what happens next, right? So, with all of that said, there's an enormous variety of research that we can do, but why TriNetX? Why do we do this? Well, for medical students, this is an opportunity for you to develop your knowledge of medical sciences. You've got a lot to learn about medicine to make use of this platform in a meaningful way. I just talked to two first-year students and I was like, okay, look, hashtag not that kind of doctor. I'm not a physician, but I did ask, what's the difference between type 1 and type 2 diabetes? That's a really important distinction for you guys to fully understand as you go forward into your research in the future. And as you go into medical school, that understanding why those two things are very different diseases, even though they both share the same name of diabetes, right? That's going to really be important for you to understand as you conduct research in this platform. So, the other thing about it is kind of the opposite, which is using your medical knowledge in a realistic way with TriNetX will help you contextualize these relationships more importantly. So you may have to memorize a whole bunch of stuff for your block exam, but to make use of that information to conduct a research study, you're going to have to become fluent in it and understand relationships between insulin. What does insulin do for one group for type 1 diabetics? And what is the role of insulin in the treatment of type 2 diabetics, right? That's going to be really important for your development long term. Um, Also, self-directed learning is what residency program directors want to see. They want to see you develop and implement master adaptive learning by digging deep into one or more areas and exhibiting mastery. It's very easy to jump onto some project in some lab that's been going for years, and you're gonna be like ninth author as you like do the references and something, and you get that publication on your CV. That's great. You might need that for your residency applications if you're going into radiology, ophthalmology, anesthesiology, dermatology, or specialty surgeries like plastics, ortho, or ENT, or some of the other procedural groups. But that's not the same as starting and leading a project. That exhibits your ability to do something new and to bring that project to fruition, to get something done. That's what people in residencies want to see. So, a lot of talking, I know, but thank you for your patience. Um, this is hopefully something that's going to be really practical and useful as you start to do your TriNetX journey. When I started teaching research at UCR, a lot of students said, I just don't know what this process is in the big scheme of things. So I came up with like what I call a rapid development process. It's kind of the big picture overview, right? And this is where we are this week, is we're going to talk about reviewing the literature, defining your question, building your cohorts. Um, in the next round of things, we're going to do your compare cohorts. We're going to talk about how to do that, propensity score matching, and generating your initial outcomes. Then we're going to talk about going back and doing this iteratively and rebuilding your cohorts if necessary to more accurately tune your project to make sure you get the results you think you're getting. You're going to get feedback and self-critique, ideally, later on, but this is something you should definitely seek from mentors and from residents and from other people in your clinical and educational life. And then you're going to learn to write up your results. So this is kind of the big picture process for how we're going to tackle these. And here's kind of the breakdown of how we're going to do it. In week one, we're looking at project and team management and available networks in the query builder. Week two, we're going to look at term groups and exploring the cohort. Week three, we're going to start looking at that. This is kind of the foundational stuff in weeks one and two. And then we're going to talk about the house that you build on top of that foundation in week three, four, and five. Um, this is kind of a clunky metaphor, but this is what we're talking about now. Your foundation supports the validity of your findings. That is having really well thought out inclusion and exclusion criteria, which we're going to talk about this week and next. Having really, really clear time and order relationships and frequency of events, understanding why a 5-year cancer diagnosis or cancer outcomes thing approach is the correct, maybe a correct time frame, but a 20-year outcome is maybe not a good choice for your study. Looking at cohort exploration and confounders, that's going to be something we're going to do in the foundational periods in week one and two. The outcome, the house that your outcomes live are the roof of, is built on selecting the correct analysis type, understanding again cause, effect, and order, and propensity score matching. That's where your discoveries are going to be. That's where that's going to support your outcomes. Not the greatest metaphor in the world, and definitely not the greatest drawing in the world, but I hope this gives you a little bit of a sense of how we build a really strong publishable study in TriNetX. Again, dumb analogy, but the main goal of approaching TriNetX this way is to ensure that your claims are valid by making the most of the platform's features, relating cause, effect, and time, as I said, avoiding common evidentiary mistakes that result in bad data, and giving you a roadmap to follow for your future projects. I know I repeat myself a lot, but it's because I've learned over the years that when people are watching things on Zoom and on YouTube, their attention may be spiraling in and out. So hopefully you heard this at least one time. Before we get into the software, I want to take you through an example study. It's hard to really just demonstrate the platform's capabilities without a use case. So I'm going to share with you a project that I did. This is, I think, a good worked example. I designed it to be a worked example so that once I got it into print, I could use it to help teach you guys how to do good studies. Not that I'm perfect or that it's a perfect study in any way, but I went through the whole process. I would never ask my students or anybody to do anything I wouldn't myself do. So I went and got a TriNetX study. I did a really high quality one. I spent 18 months working on it and I developed it. So this is a good way to also develop some understanding of the tacit knowledge and discuss ways of thinking about things in a worked example. Um, I'll be using this project to kind of illustrate various features of the platform throughout this course so you can keep an eye on it. So where did this little study I'm talking about come from? Well, it came from late night Instagram doom scrolling. I was watching Instagram one night, and social media is, as you know, full of questionable medical advice. Like this guy, my wife was at the time pregnant, and so this guy's stuff kept getting resurfaced to me because he talks a lot about maternal nutrition. He's very German, apparently, according to him, and he stands in front of the camera in this white t-shirt and he makes very important pronouncements in a monotone voice. So he said in this video, this claim that Alzheimer's is often a physician create a caused disease because they're not trained in nutrition. Alzheimer's disease is caused by a decrease in myelin surrounding your nerves strains, making up 75% of your brain weight. That myelin, making up three-quarters of your brain weight, is almost 100% cholesterol. Therefore, suppressing cholesterol in healthy adults with statins is the major contributor to the global Alzheimer's disease pandemic. Alzheimer's didn't exist, also not under another name 40 years ago, and exponentially increased with systematic abuse of statins and fear-mongering cholesterol. Suppressing cholesterol without medical necessity does more harm than good, backed by evidence. Okay, so now you guys got my impression of this guy. I think it's a pretty good impression. But that doesn't even pass the smell test. And I'm not even a physician. I was like, wait a second, none of this makes sense for a couple of reasons. Let's look at these claims one by one. Alzheimer's is a physician-created disease. Fundamentally not true. That's just physician blaming. That's make America healthy again thinking. This claim, Alzheimer's didn't exist, not and also specifically he says also not under another name. 40 didn't exist 40 years ago. Factually untrue. 40 seconds in Wikipedia will tell you that this is nonsense, right? And if you can't trust that basic claim that he raises, like nobody asked him to say that, how can you trust any of the rest of what he's saying? It not, by the way, Alzheimer's was identified in 1906 by Alzheimer, and the first statin wasn't produced until 1987, over 80 years later. Alzheimer has already been, he'd already identified that specific type of dementia several years even earlier than before they named it. So none of what he said makes sense. That's like 10 seconds in Wikipedia and you know that. Um, this guy made me so mad that I spent 18 months developing a study to refute this bogus claim and using it as specifically an opportunity to show you guys how TriNetX work. But with that said, maybe people should be on statins, right? Like I'm hashtag not a physician even. I would say physicians don't necessarily have godlike knowledge of all aspects of medicine at all times. That's why we do research, right? So if you investigate his claims a little bit, there at the time right after I saw this video, there was a study that came out that indicates that maybe fewer people might need statins. So maybe our risk profile who should be on statins needs to be adjusted a little bit, right? That maybe some people who actually should be on statins are not getting it, right? Because of a whole range of different parts of the algorithm that physicians use to determine who should be on statins, and maybe some people are not really benefiting from it. Their cholesterol difference is marginal enough that some of the side effects and maybe some of the downstream things, pancreatitis, brain fog, some of the side effects are not worth the cardiovascular improvements. In fact, Eric Topol, who's a very famous physician, posted an article that came out the other day that indicates that maybe statins might disrupt metabolism in muscle tissue in ways that might make it not a great idea for certain kinds of patients under certain, especially older patients and stuff like that. But my main point here is it's not something you can stand in front of a camera with a white t-shirt and pontificate on. This is a complicated situation when it comes to Alzheimer's. Things to consider. Statin dosage and whether that dosage increases over time as older people are not as able to metabolize cholesterol effectively. Length of treatment, were people on it for 3, 5, 10? We have people who've been on statins in some cases for 20 years. Comorbidities like vascular diseases and stroke. One of the frontline things is using statins immediately post-stroke to try to help regulate cholesterol if people are way out of whack. Dietary considerations, beef consumption is absolutely correlated with AD rate increases, irrespective of cholesterol. It could be prion situations that are going on here that have nothing to do with statins and nothing to do with anything physicians are doing, right? Beef consumption by itself may explain some of the increases in Alzheimer's. Probably not all of it, but some percentage of it, according to existing research. Poor understanding of Alzheimer's causes. Alzheimer's is like 12 diseases in a trench coat. Fundamentally, the research does seem to indicate that it is a cardiometabolic situation, right? There's generally some kind of insult, whether it's viral, for example, an explosion of viral particles replicating in the brain. Alzheimer's brain tissue taken from deceased patients with Alzheimer's indicates that there's much, much, much higher rates of herpes zoster virons in their brain tissue at that time. So that could be an insult that causes runaway inflammation that causes the production of amyloid proteins and the inability of the brain's glial cells and other garbage men in the brain to get that tissue out, coupled with inflammation from insulin sensitivity, all sorts of other stuff going on here, right? So the beta tau proteins that are the hallmark of this disease may have kind of nothing to do with the cholesterol, except actually that interestingly, cholesterol is the fundamental unit that is used to synthesize by cells to synthesize beta and tau proteins. There's also genetic dimensions of greater understanding of ApoE3 and 4 indicates that there is a big genetic people with double ApoE4, double ApoE3 or double ApoE4 have much, much, much higher rates of Alzheimer's because their cells have two copies of the amyloid production gene. There's also an ethical issue here. If there's no answer to this necessarily, but if statins help with triglycerides, is it ethical to withhold them to protect against the possibility of Alzheimer's in the distant future, right? Would it be worth it to prevent? And this is something physicians and their patients have to discuss, right? Is it good to not take statins now and protect maybe against Alzheimer's in the future by not disrupting your cholesterol metabolism? Or is it better to prevent atherosclerosis and all the other stuff we know statins have rigorously been shown to improve and risk vascular dementia right now, right? By having microclots all throughout your brain caused by fatty deposits in tiny blood vessels. So this is not a subject of I mean, it is a subject of academic debate, but it's not something we have to imagine. There's a ton of research out there. So I found two different meta-analyses. This is a meta-analysis of observational studies, similar to what we would do in TriNetX. And they found that, in fact, all rates of Alzheimer's and dementia were reduced by as much as 32% in patients in all of these different observational studies when you average it across there and you adjust it in all the ways that they did. Similarly, and interestingly, the study on randomized controlled trials did not find as much of a savings, as much of an impact of statins on the treatment of Alzheimer's, because obviously people want to use these drugs and see if it's an easy way to help reduce rates of Alzheimer's in patients, right? So, well, what about real world data? Well, until we came along, there were no real TriNetX studies on statins and Alzheimer's specifically yet. But it's a perfect analytic tool using real world data, that is data drawn from the clinical environment, electronic health records in this case, is maybe a perfect analytical tool because it's hard to get longitudinal data on Alzheimer's patients. People drop out, they die, they become no longer able to consent, all sorts of reasons that people that it's really hard to do in some cases prospective randomized controlled trials on this. And it's hard to randomly assign people to statin, no statin groups, right? Like, how do you decide who goes into one or the other? You can't really randomly do that. You can't withhold treatment unless people volunteer not to do it. And there may be some common feature of the no statin group that causes them not to volunteer that has nothing to do with, or that can't be randomized for, right? So you might not even get a good methodological application. Cohort matching can be challenging due to multiple comorbidities. You can have Alzheimer's patients who have already had strokes or are about to have strokes. They have strokes during the RCT. All sorts of stuff can impact that. It also allows us to ask some really specific questions about dosage, about length of treatment, things that are really hard to do in prospective studies. So we had a bunch of different questions ultimately, but to what degree do statins impact people's odds of developing Alzheimer's disease is the kind of big picture question we ask. We have an H sub zero, right? Null hypothesis stating that statin use is not associated with any changes in likelihood of development in Alzheimer's disease, and statin use is associated with a lower likelihood of Alzheimer's disease, is our hypothesis based on the existing literature out there. So in the study, which I will put a link to in the chat so you can see the kind of final version of it, these data on this screen are a little bit outdated. This is a cohort diagram, and this shows, I strongly, strongly encourage all people who develop TriNetX studies to develop a cohort map. If not, use mine, then do something really similar, because it's kind of like a Prisma diagram and a meta-analysis in that it will help you identify and help people really clearly understood your inclusion criteria, your exclusion criteria, who was, what your time relationships were. All this stuff can be represented visually really quickly. I also propensity score matched my cohorts in the study, meaning that I tried to use these tools, these statistical tools, to make sure that we didn't just have one group full of older, sicker people than the other group. If you don't propensity score match this, you can see, I'm just going to zoom in here. Prior to propensity score matching, the average age in my control group, my non-statins group, was almost 13 years younger than the statin group, right? Which means that what we might have seen if we didn't propensity score match is just simply that older, sicker patients get Alzheimer's at higher rates than younger, healthier patients, right? Using propensity score matching means we've reduced as much as possible the statistical, the likelihood of being in one group or the other based on the characteristics that we used in our matching profile. I'll talk way more about this later on, but propensity score matching generally is a statistical technique used to reduce bias in observational data, the same way that randomization is used to reduce bias in randomized controlled trials. Just more technically, it's a quasi-experimental method in which the researcher uses statistical techniques to construct artificial control groups by matching each treated unit with a non-treated unit of a similar characteristic. So using a control at a different group, but we're doing one-to-one matching of these people so that there's no difference between the compositions of these groups. We then generated an outcome. Ours was a little different than this in our final version, but roughly patients on statins were about uh, 70% as likely to develop Alzheimer's as their non-statin treated counterparts with hyperlipidemia. We developed this as an old version of our poster, but we developed this and we presented it at uh, the Internal Medicine Conference, the Western Internal Medicine Conference. Um, and you can see that the difference between the two groups, even later on in our further versions, was like the difference between 0.22 and 0.489%. So I can hear biostatisticians out there saying things like 0.23% is clinically meaningless. Well, yeah, at the population level, though, 0.23% is an enormous number of people. I did the math. If these numbers held true, 0.0023 of 13 million statins patients, right? The potential pool of people who could go on to develop Alzheimer's in that pool. Um, that would lower the risk of Alzheimer's for 29,900 people. The lifetime cost of Alzheimer's care is an additional $400,000 per person. So 29,900 people times $400,000 is roughly $11.96 billion that we would save. The total Medicare costs in the real world are about $320 billion for the entire program. So this would just by itself, giving people statins could reduce costs by about 4%. And I bet we can all think of really great ways we could use $12 billion to improve the healthcare of Americans. Most medical plans, though, cover 100% of generic statins. When I was on a statin a year or two ago to see how it impacted my health, um, I literally paid $0 my healthcare thing. They just gave them to me because it's ultimately cheaper to just give people the statins, the generic statins, the atorvastatin, than it is to charge them for it, right? It ultimately reduces their long-term rates of morbidity. Um, the Cohen's rate of this, Cohen's D value, which is a measure of um, how much of an impact this makes. It's a little easier for certain people to think of, even though odds ratios are also an impact factor, was about 0.51, which is a medium to large effect. And one thing to keep in mind, though, is that these were otherwise very healthy people. We removed all common comorbidities that might cause Alzheimer's to really zoom in on the effect of that statins in generally otherwise pretty healthy people. That is, they didn't have, there's a whole laundry list of stuff we excluded because we wanted a very, very narrow band of otherwise healthy people so we could isolate that and create a kind of natural experiment. Here's the final print version of it. I completed it with a group of medical students last year. Let me see if I can put this. You can find it on the Journal of Alzheimer's Disease. Um, and it was published on February 27th. So let me just put this in the chat here if you want to go read it. It's quite comprehensive. We tried to be as thorough as we possibly could. I tried to be as clear as possible so that when students would look at this in the future, they would understand exactly what we were trying to accomplish with the study. Not really sure why my cohort diagram didn't show up. I may need to refresh this. I don't know. But in any case, you'll see how we set up propensity score matching and why we did it the way we did. All sorts of things like that. So we're going to build it today. We're just going to talk about the cohort. I'm going to make a quick note for 2026 that we have some upcoming changes to TriNetX. Some of the things I'm going to show you in the platform are going to be changing. They're moving some of the icons around and stuff, but fundamentally, they're not that different than the past. A very, very exciting change that's going to be coming up that will be available in due time to our community at UCR is the AI help tool. They've developed a tool that will help you use the platform and understand different aspects of the platform. Instead of just having like a flat help document, you can chat with this chatbot and it will help you understand what's going on. And they're also including an AI design tool. So you can say like, help me find all codes related to pregnant women. And it will come up with a list of them that you can then import into your study much more easily than having to search for a bunch of different codes and try to get them all together. Okay, so with that said, we're going to jump into some basic stuff. Part one, creating a new study. there's a big button when you log into TriNetX that says create a new study. Let me just jump over here. You will find that, of course, I'm locked out. Um, Okay, you'll find that right over here in your tool. Then when you click on that button, it will ask you for a bunch of different stuff. You're going to see a screen much like this. It's going to ask you for a study name. You're going to have to choose one of these options. Generally, I recommend other scientific research and selecting some of these boxes. You're going to look, sorry, at your primary therapeutic area. I usually use public health, but you can use a different area. It actually doesn't really matter for these kinds of studies. And you're going to also potentially consider using the share study icon down here, or checkbox down here, because share study is how you add other people, including me, to your study. So if you want me to take a look at your study when you come to meet with me, you can click this box and add me to your project. Um, you can see here I highlighted some of these core areas as well. Let's talk about some key startup features. We're talking about available networks and the query builder itself. So the global network actually has more than this now. It has closer to 193, as I said earlier, 193 million patients. And just log into one of my studies here. This is my test account here. You're going to be able to find these networks. Yours are just gonna, when you come to UCR, you're gonna be your loadout's gonna include the Global Collaborative Network, the UC Collaborative Network, and the United States Collaborative Network. You can see there's about today 118 million or so people on 69 networks across the United States, 194 million-ish on 181 networks in the United States. And then in the UC Collaborative Network, about 3.5 million patients. So I generally, depending on what you're using, I generally recommend to our students to use the US Collaborative Network because it tends to be comparing the US, patients in the US, and mushing them together with patients from the global network sometimes can water down your overall results and lead it to be a little unclear. Let's talk about the query builder. The query builder is the name we give to this tool over here. It's got a bunch of different options in it. When you click on it, you're going to see here demographics, diagnoses. There's an oncology tab, which we're not really going to get into today, but it can be quite useful. It has directly dialed into the oncology database in the National Cancer Registry. It has procedural codes, medications, labs, genomics, and visit types. So there's a lot of really great stuff going on in this query builder. And we're going to talk about a number of these different features. I'm going to kind of blow through some of these so you get a chance to go try this out on your own. The first thing you're going to notice in here is when you're at the query builder, you can either look for things like, for example, we're going to look at the diagnosis tabs. You can look at, I'm just going to look for A00 through B99 here is infectious and parasitic disease. So you can search for tuberculosis here and select it to add it to your cohort. Or you can always go in and try to search for terms like tuberculosis, right? And it'll give you a whole list, a searchable list of all of the potential related terms in here. You don't have to add all of them in. We're going to talk about that in a second. But there's a whole bunch of different ways that you can add these in to maximally find the correct group of people. You can also, as I have in this example, asthma, right? So if you type in asthma, you can see both the code for it. Here's the 7.4 million patients tagged with asthma, but you can also see in it all of the other places that asthma shows up in here, including, for example, doing an asthma action plan or asthma education and some of the more obscure components. The TriNetX window is divided into two components. I'm just going to add asthma. It's got the must-have category and the cannot-have category. So we're going to make sure that we're looking for people who have asthma but who do not have tuberculosis. So you can see here, this group of people, when we hit count patients, are going to have never had in their whole life tuberculosis and will have definitely had asthma and been diagnosed with asthma at some point in their life. When you add something to your code, we're going to talk about two buttons that pop up over here when you mouse over any term that you add to your study. This is the term filter, and this is the term hierarchy. The term filter allows you to add some additional information to here. I'm actually going to add a drug so we can look at the term filter a little bit more in detail. When you click on the term filter on a drug, especially, you'll have additional information in here, including in this case, semaglutide, whether it was an injectable or an oral product. You can see whether it was an unknown brand or whether they were able to specifically identify whether the person was on Ozempic or Wegovy, right, which have two different things. And you can also see things like the dosages in here. Um, Looking at lab values in with the term filter will allow you to see the different lab value ranges that are available in here. So you can see across the 19 million people with an A1C lab value in TriNetX, you can see how they're distributed. You can see that, like, obviously you have most people kind of centering on a relatively healthy pool, but you can see as you go further up the pool, fewer and fewer people have like these very, very high values. So you can say we want to make sure that we're including people with A1C greater than 6.5, right? Pre-diabetic folks or low diabetic folks. And then you can add that in here and it'll let you do that. Um, in addition to the term filter, there's the term hierarchy tool, which allows you to jump directly to the area of the hierarchy in the ICD-10 codes, which enable you to find different diseases. So let's say you search for asthma, but you want to get in there and see more of the different ways that asthma is broken down in the ICD-10 system. You can jump to it using the term hierarchy function to do that. What you will find is that basically a big picture version of ICD-10 codes is that they're kind of like the Dewey Decimal System of disease identification. They're organized generally by system. So you can see here are all the different circulatory diseases, hypertension, ischemic heart disease, cerebrovascular diseases. All of these are all kind of pooled together in a hierarchy like this and kind of grouped in a kind of sensible way. Generally across the world, this is used pretty widely, and it's very widely used in America as it's been very well thought out. There's some limitations to it, but understanding and learning about the ICD-10 code system will only benefit you because when you go out into clinical practice someday, you will encounter it, and you may even memorize a great number of them. So, term filters and term hierarchy. I also want to point your attention to Boolean logic and or tools that are in here. You can see that in here in TriNetX, you can specify whether you want people to have asthma and semaglutide and an A1C over 5.5, or asthma and people with semaglutide or A1C. So you can pull these things together in very, very specific ways to get exactly the sub cohorts of people that you want to see in your study. Ultimately, though, once you've identified and set up all the different people you want to have in there, you're going to hit this blue button up at the top that says Count Patients, and that's going to help you actually pull those people from the TriNetX record. It's going to spin for a second, so while it's doing its thing, I'm going to switch back over here and continue moving forward. When you hit Count Patients, every single time you hit that blue button to update that, you're going to get a little card that's going to pop up over here representing that query. So if you go in, if we change and take out asthma and just leave it as semaglutide and A1C, and we hit Count Patients again, going to get another card. If we remove tuberculosis, going to get another card, right? You can see here, we just got this card of 652,000 people from here. So this allows you to jump around between past versions of your cohorts and current versions that you want to save. And you can name them and add notes like added TB to exclusion in here. You're gonna say this is asthma, oops, by GLP-1 by no TB, right? It's your cohort. And then you can, I recommend rigorously naming your title cards to track them. Otherwise, you can lose sight of them really easily. And so finding a good nomenclature for yourself that helps you stay organized, it's not too complicated and is easy to use, is going to be really important. A couple of quick conceptual notes on cohorts and outcomes. Your cohort should never include the outcome that you're going to use to conduct your analysis. if you include, for example, in this group, I'm just making this up, Alzheimer's, and you want to see if this group of people has Alzheimer's, well, you're going to get a circle, right? Cohort, a cohort of people with Alzheimer's is going to include people with Alzheimer's. And so you don't want to include the outcome of interest in your cohort definition. Um, if my cohort, again, 100% of my population, if I include my outcome within my study, that's going to be you're not going to get a correct count of what's going on in your thing. The only time that you would include your outcome in your analysis is if you wanted to just see generally, well, in this cohort of people, how many of them do wind up going to get Alzheimer's? Should I even bother doing this study, right? Of these 652,000 people, how many go on to get Alzheimer's disease? Well, I'm going to say, all of these things are true. Let's go see how many people are in here. If it's like 20 people, well, that's not really going to make it for a very good study, right? We're going to have such a small sample size that's not going to be a meaningful outcome. We got 7,880. Maybe we should continue with my analysis here, right? Because there might be something unique about this group that we want to dig into, and 7,000 people might be enough to get a good analysis going on. So that's a big picture view of how to use some of the search tools in there. We're going to jump in really quick to part 3. Doctors don't pay money late. Starting a study. Doctors don't pay money late is a great acronym that one of our students, Jonathan, came up with a couple of years ago. It stands for demographics, diagnoses, procedures, medications, and labs, and genomics and visits. So these are your general tools that you can use to look around. So demographics includes, as I said earlier, age, sex, race, ethnicity, marital status, and vital status. For these purposes, you can look for, by the way, in TriNetX, you can find out if people died, but only if their death was recorded in their electronic health record. If they died and it wasn't recorded in their health record, it's not going to show up in their electronic health record. Or if they didn't die in their health system, they died at home, maybe it's not going to show up. Demographics, age, and sex criteria. There's a little button here. People often ask me, how do I identify whether, we have male or female people in my study? Well, you can click on this little filters area. They actually changed this thing a couple years ago. And you can edit this here and say, I want people older than 18 years old, and I only want female participants. And then you can save that, and you will see that your overall number of patients decreases, and you can see that over here, that will be part of it. You can review all of this stuff as well as part of your analysis, and you can do some, you can, obviously hold on to this as you go and change out some of your cohorts to compare male versus female groups and things like that. Just make sure to remember to save your criteria before you exit that screen. Demographics, as we talked about earlier, you'll see that in the cohort builder. Your ICD-10 diagnostic codes are going to be searchable. As I mentioned a moment ago, you can look for specific codes, but sometimes things you're looking for might be collapsed into other things like other skin conditions, which can be disappointing, but it means that the committee that steers the ICD-10 system didn't think it warranted its own code. So that can be sometimes a problem with your analysis. As I mentioned earlier, there are a number of restricted, sensitive ICD-10 codes, and here's a list of them. That one I identified earlier, X52, is prolonged stay in weightless environment. You can see some of the other ones. People with a BMI over 50 in that, not in their lab value, but in their Z code, because those people there's so few of them, it's really important that they be able to not be identified negatively and that kind of stuff. So you can set in your lab values BMI of 40 and over, and then anything above 40, it just collapses down into one big code, and that provides enough anonymity. You'll also see CPT procedure codes. This is the pay and doctors don't pay money late. These codes can be very precise because these are the billing codes that insurance use to reimburse physicians. For example, people who do atherectomies, right? Really specific procedural things, whether they're using one type of tool or whether they're using computer-assisted stuff. You can use the term hierarchy function to see these related codes, though, and see how this hierarchy goes. One thing you'll find, though, is they can be very specific to like left toe, metatarsophalangeal joint, right? Like really, really specific things. And that can be both beneficial if you're very specific, asking a very specific question, or very annoying. One thing that's good is all of this is very Googleable. If you're trying to figure out like what code should I be using for this particular procedure, you can type it into Google because medical billers do this all the time, and Google will surface it for you pretty quickly. You can also search for it using this tool. So amputation procedures on foot and toes, you can get much more specific. Here's the transmetatarsal amputation on the foot. However, don't forget that in addition to CPT codes, there's a ICD-10 procedure code system to make things more confusing. There's an ICD-10 diagnostic system. That's the main diagnostic system we're going to use. But there's also a procedure code system. It's in its way much more organized in some ways than the CPT system. It's parallel to that, though. It's less commonly used by health systems. The ICD-10, I'm sorry, the CPT codes are used by with hundreds of millions of patients or dozens of millions of patients, tens of millions of patients. But the ICD-10 procedural code system is only used for about 16 million patients in TriNetX. Again, there's a whole bunch of different reasons for why one system might use CPT or ICD-10, but you generally want to try to pick the codes from both of those systems so you're not missing out on a nice pool of patients. ICD-10, just FYI, is generally more structured around parts of the body than the CPT code system, which is more around procedural relationships. So it can take a little bit of practice to find both of these properly. Medications you can search for by brand name or generic. You can use the hierarchy tree, as I pointed out earlier, to find related drugs in that category. For example, GLP-1s are in kind of miscellaneous glucose management tools, medications. You can also use filter terms to pick lab type and strength. This is the late, and doctors don't pay money late. Lab values can be included in the system depending on the lab type, as I showed you earlier. There, you'll find some of these labs are marked with a code that's or an identifier called TriNetX curated, and this bundles multiple tests into one analysis. So many different hospital systems you can see kind of over here use different test types for A1C, but TriNetX has harmonized those into one pool of 19 million people that you can look at instead. Next week, we're going to have a little more technical training on advanced cohort design and the explore cohort function. But this is has been a general description of the information that you'll be able to access in here. So I'm going to close out today with a little bit of information on developing a project. We're kind of out of the technical stuff that I described earlier, and now we're going to talk again about some more conceptual stuff. I'm going to say, Rhodes, I want to get you guys started on the right foot with this boot camp and also in the right way. People often are like, thanks for the software demo. Awesome. I'm just going to get in there and just start playing with it and just throw some stuff together and see what I get. Do not do that, right? You'll say, I'll come up with a good idea as I use it. I'm just going to throw stuff in there and see what I can do. Great TriNetX projects don't start with the software. They don't start with the platform. They start with the library, right? This is the University of Washington Library where I wrote parts of my dissertation. I love UW. It's a great school. It's number 12 in the world. Yeah, U.S. News and World Reports came out the other day. But I do know that the best way to get out on a good foot with your project is to start with your literature review. This is what I teach my students all the time. Here's why. Depending on whether you are at UCR, maybe if you think of research as like a kitchen, I'm going to use a lot of food metaphors coming up. UCR is maybe like a little more rustic, like the kitchen on the left, right? We don't have a hospital facility quite the way some of our colleagues at nearby institutions at UCI and UCSD have advanced facilities, or our colleagues at City of Hope maybe are more like that kitchen on the right. They have a really, really, really advanced laboratory for conducting research and advanced armature for doing that. But TriNetX acts more like an instant pot. I don't know if you can raise your hand on Zoom on Zoom if you've ever used an instant pot before. But it's a tool. The internet loves it because if you buy an instant pot and you're cooking with it, a lot of you guys own one, maybe, right? They went out of business because they made a product so good that nobody ever needed to buy a second one. They mostly never break down. But if you have an Instant Pot, especially if you're like, pressure cooking foods, it's great because if I have one and if you have one, it's the same recipe, right? Like you don't, we both, no matter what our kitchen is like, whether mine is more rustic or more futuristic, our Instant Pot is the same. And that way, any recipe you give me, I can go ahead and use in my Instant Pot to create new recipes even, right? Um, and every dish, every study, I'm getting hungry as you can tell, every study needs a recipe, right? For example, you won't know what is that green stuff on top there. Is that avocado? Is that parsley? Is that cilantro? Is it some sort of herb or is it a vegetable? The recipe will tell you that that's avocado, right? So you know, and sorry, cilantro is on top of that as well. Um, this will help you understand how to develop it. If you try to go into your kitchen, unless you're like a master cook and you really know what you're doing, YOLOing a recipe is not a good idea. You're going to wind up with something potentially inedible, right? Existing TriNetX studies serve as your recipes, right? They've already made it through peer review, so that doesn't necessarily mean they're perfect, but it does mean that at least people have given a good solid read to it and tried to break it down, right? The methods section in a good TriNetX study will usually lay out exactly how their studies were constructed, exactly what codes they use, exactly the demographics, the time relationships. Any good study will do that. Bad studies don't. Don't use studies that don't give you that information because a good one means the people who are doing it knew what they were doing and they included that information for you so you could replicate it yourself later. Um, it also identifies any groups or codes that were excluded and when that occurred, and indicates whether and how propensity score matching were used. So, where can you find TriNetX recipes as you're starting out on your project? Well, TriNetX, as I pointed out earlier, has a real world publications resource where they both have a grand list of all of their studies because they monitor that pretty regularly, but they also have a lot of other information. They have a lot of other sources for identifying those. You can also just type in to Google Scholar, TriNetX, and your interest and see what's already been done. That will really give you a sense for the studies that have been done. For example, I put in TriNetX and Alzheimer's. Oh, here's a very highly cited study on COVID-19 and Alzheimer's from 2022. So maybe if I want to do something similar on COVID-19 and say vascular dementia, I could maybe start out with their study as a template for creating my new study. And that's a good way to engage in science. There's nothing wrong with that, as long as you're obviously not plagiarizing them. Even updating their findings could be a potential valuable tool, right? With additional years of data. The Scholarly Activities portal, I also have a curated list of studies that I showed you guys earlier, which you can find in the beginning of the video if maybe you missed that. If you can't find a study in your area of interest that's already been done to serve as a starting point, you can use meta-analyses, systematic reviews, and scoping reviews because these people have done all the work of reading everything for you and they will tell you where something's missing. Going back to that analysis of meta-analysis of randomized controlled trials I talked about earlier on Alzheimer's and statins, they specifically said in their study, in their conclusion, we could not control AD related factors because there's no detailed data such as cholesterol, ApoE4 gene, gender, vascular diseases in the AD patients. So we could not analyze how these factors affect the efficacy of statins in the treatment of Alzheimer's. So because the foundational studies did not include that information, this systematic review can do that, which made me go like, aha, I can do that with TriNetX because I actually can go back and because I'm doing an observational study, I can make those inclusions and exclusions in a way that produce a higher quality thing. So earlier on, I told you about a rapid development process. Here's the even more rapid process for this. I tried to create a slimmed down process to make this an even faster jumpstart for you in your project. Number one, select your area of interest. Number two, identify in a similar area or similar type of study that used TriNetX in your, maybe it's a slightly different disease or slightly different population, but you can adapt that basic structure into your new study. That will help get you through the whole process of figuring out what are my inclusion and exclusion criteria, what's good, what's bad. That can be really helpful. Read the study to really deeply understand their recipe. Pull out those key features, the ICD-10 codes, the CPT codes, timeframes, cohort structures from that article. This year, I'm going to provide a reading template coming up that you can use to help you pull out key features from these articles. You can reconstruct the study in TriNetX and then refocus the structure on your topic and cohort, examine your outcomes, and check that with an expert. This is probably the best combination of rigor, making sure we're not producing junk, that we're producing high quality, valuable, important research, but also leveraging existing research in the strongest possible way with this tool set. Some benefits to this approach: by making sure that you attend to the following features in your study, we can do our best to make sure your study will be more likely to add to valuable population health and clinical practices by filling a key gap in the research. Study will be less likely to produce a junk study that adds additional noise and uncertainty to an already crowded scientific field. And your study will be more likely to satisfy reviewers as to the comprehensiveness, accuracy, and methodological understanding of the project. Big picture stuff. Quickly, I'm going to give you a couple of examples. We're going to just look at a worked example of a good TriNetX study for a couple of minutes. What are some of the, I just want to identify some of the 5 features that I'd like to see in our school's TriNetX studies and publications, 5 things I think you should do. Um, Key features of a good study. These are actually my top 7 things I think in here. I'm going to go through these really quickly. So, number one, the study should include a clear layout of the inclusion and exclusion criteria for the cohorts. That's something that's really important for them to list out for you in a way that you can make sense of it. And when you do it, it should be detailed enough that somebody else can read your study and go back to their own TriNetX and basically redo what you did. The cohort construction diagram is another way that you can know that there's a good quality study, and it's something that you can do to help make sure that you're keeping track of your logic. I made you a template. If you go to the Scholarly Activities site, you can make a copy of this to your account, and you can use it yourself. There are clear temporal relationships. The relationships of time and events in the TriNetX study are really, really essential. Making sure that pregnancy comes before, postpartum preeclampsia is a really key feature in order to make sure you're assessing things correctly in your time frame. Understanding relationships over time is really important as well. And making sure that you can be clear about how they did it in their study is going to be really key. Use of propensity score matching and how they did it, what factors they use, and how they thought about it is really important when it's appropriate. Using clear identification of potential confounders and means of mitigation in their cohort construction is also really key. A way you're going to know also that studies did a good job is what we typically call table 1. It's kind of like not necessarily always table 1, but in most studies, it's a table that shows the pre and post matching values for studies that you do using the propensity score matching. And you'll see why when you read these, why it's so important, because you want to know how much of a difference, how effective was their propensity score matching in reducing differences between the two groups. I even have a template for you here, but my TriNetX publication toolkit will help with that as well. You're also going to be looking for clear representations of outcomes. Even though this is actually from a different study, having things like forest plots, graphs that really make it clear what their outcomes were is really tables that are very, very clear and easy to read. That's going to tell you that you're looking at a good quality study, and that's going to be what you're going to want to include as well. I include some templates for you as well, and also in my TriNetX publication toolkit, which we'll get to later, it will make you that based on your TriNetX data. So, in summary, these are some of the 7 things that I think you should be looking for and you're going to want to include in your own study. Really quickly, I know we're a little bit over time today, but I want to share with you some examples of student projects that we've seen that have been really effective. A student who's now a resident in dermatology, Roy Mendoza, did a great study looking at racial disparities in melanoma metastasis, hypothesizing that he would see some differences because, there may be Latino patients, for example, who think, well, I'm not white, I don't get, his skin cancer, but and thus don't necessarily maintain good, skin cancer screening and prevention. They may wind up accidentally going on and being unassessed for melanoma that then metastasizes into lymph, brain, liver, and bone and intestine tissues. And he did, in fact, find that, yes, there were small but measurable and consistent differences in risk, increases in risks for Latino patients versus white patients in all of these areas. A second study that's really phenomenal that a student, he's just completed his health system science project with us this year, his research and inquiry project, was looking at disparities in prescription rates for omalizumab and dupilumab, which are 2 um, asthma medications. He's a third year student, and basically what he looked at, he did a three-chamber design for this. The first was he found a study that did compare omalizumab, which is an older drug, to dupilumab, which is a newer drug that was approved in 2017. And what he found was what the research found, which is that dupilumab is in fact a superior drug and leads to better control for acute respiratory distress and respiratory failure. However, the study that he read also just happened to have a footnote like, oh yeah, and it looks like in our study that Black patients were being prescribed this medication at a lower rate. He's like, that's weird. So we pulled that out and then did a second follow-on study. So we're able to replicate the existing research in TriNetX. We're able to show that, yes, also in TriNetX, we did see a small but statistically significant difference in prescription rates of dupilumab to Black patients compared to white patients. And we found that Black patients on dupilumab compared to Black patients on omalizumab were less likely to have acute respiratory failure and acute respiratory distress. So, using TriNetX, we were able to replicate existing research, demonstrate that yes, there is in fact a disparity in prescription rates in this data set that we expect to see based on the existing research, and that one step further, that disparity actually appears to lead to worse outcomes for Black patients. So harm is being done, and the next phase of research would be to go out there and quantify that harm prospectively and to do a quality improvement project at a different health system to help to make sure that Black patients who would be helped, who can get dupilumab, it may be slightly more expensive, but have the insurance and can get it, are given that drug more frequently to educate providers about making sure that it's prescribed where applicable. All right, so we're closing out tonight. Thank you for your patience, and we will be done very shortly. But I'm going to leave you with a couple of sample problems to try between now and next week. Please take a screenshot as we present them, and I'll give you guys my solutions next time. I'll take a couple of looks at them next Tuesday. So create some cohorts for the following scenario. So we're going to look, this first problem is going to help you assess demographics, diagnoses, and procedures, your ability to command these tools. First, I'd like you to try to create a cohort of women between the ages of 18 and 45 who have had laparoscopic surgery and a diagnosis of fibroids. So just see if you can get those together and make sure you've got your Boolean logic and you've got your CPT codes and your diagnostic codes all aligned and your demographics all aligned to produce that cohort. And I'll show you a screenshot of what that cohort will look like next time. Number two, for this week, I'd also like you to think about creating a cohort of type 2 diabetic patients with a BMI over 30 who were treated with 5 milligrams of semaglutide but never received metformin or SGLT2 inhibitors. So this will help you to see whether you understand properly how to set up your diagnoses, labs, and medication dosages in some of the ways that we've described in the interface today. So give this a try in when you have your TriNetX account. For first years who are starting out, just an FYI, we're going to have to wait until you get issued. I believe on July 1st, you're going to get issued your at medschool.ucr.edu account. I'm going to need that in order to create your TriNetX account. But if you do currently have a TriNetX account, please go ahead and try these out. Take a screenshot of it and see how you match up over next time. Next time, we're going to take both of these examples and add some additional wrinkles to them to take advantage of some of the other cohort tools. Next time, we're going to talk about defining and exploring cohorts and get deep into the development of cohorts that capture exactly the groups of people that you think you want to capture. That's it for our didactic component tonight. I got to run in a couple of minutes